So, I mean, the reason for her talk is to basically just give us a background, what happens in the lab, I mean, how do we test for these receptors, just to put it clear in everyone's brain. Thank you, Dharshnee.
Hi, good morning to the audience present and those online. I see that the speakers before me did quite deep dives into their subject matter, but I'm going to frolic in the shallows a bit and just tell you briefly what the clinician needs to know about the breast pathology report that we generate. Okay, so bear with me if it's some things that are quite apparent or quite obvious, but I just think that sometimes going down to basics makes a huge difference. So I just stand here. Okay, thank you. The first mistake I made was obviously saving this as a PDF and not as a PowerPoint on a system that works purely on PowerPoint. So let's see. So there's been much evolution in the diagnosis of breast cancer. Remember, at one stage, we were diagnosing breast cancer purely on morphology. Then we've obviously added immunohistochemical analysis to it. Then further on, we've added sequencing, molecular diagnosis, to the point where we're having MammaPrint, OncoDX, Blueprint now, obviously telling us what the tumor is, what's its gene signatures, what is a targeted therapy going to do, what's its prognostic factors. Right, but in the interest of job security, I would like to say that there are certain, what can we say, certain things about the tumor that hopefully the pathologist will only be able to give you without actually having the machine being able to do that or AI being able to do that. So what exactly do we answer? What questions do we answer in the breast report, or what questions do we answer that's relevant to you guys, the surgeons and the oncologists? Well, first of all, is it malignant? If it is malignant, how are you going to follow it up? Because we'll obviously tell you features about the tumor that would need to be specifically cared for by the oncologist or the surgeon. How is it treated? And I think the surgeons are especially concerned with, did they take everything out? Oh, okay, I think so. Don't think you can see that picture, but a lot of the times I think that in the lab it becomes a bit obscure, and I know that we always end our reports sometimes very carefully saying, please correlate clinically. Tell them it's something pink, or tell them it's something that, but that we'll just want to look at imaging just to double check as well, okay? Especially if it's small tissue diagnoses that we need to make. So I always say, everybody wears a different hat, and I think different socks are made for different people as well. As you can see that we've got Superman socks for the surgeons, but the pathologist, it's a little bit obscure. We have to figure out, are there socks? Can we wear them? What can we do with it? What do we need to do on this to tell you more information? Okay? Okay. So there are certain prognostic factors that go into the categorization and the risk factors for breast cancer. I'm just going to go over these briefly. There's category 1, 2, and 3. In the first category, obviously, it's obvious things like tumor size, the lymph node status, micrometastasis, the histological grade, the mitotic count, and obviously the hormonal receptor status. And then we go on further to HER2 new expression, P53 mutations, and lymphovascular invasion. So these, like I said, are the predictive and prognostic factors of breast cancer. We start off obviously with axillary node status, the tumor size, lymphovascular invasion, the subtypes, which are very important, response to neoadjuvant therapy, and we can use many scales for this. The commonest one is obviously the Miller-Payne. We'll go into that later on into the talk. And then HER2 new expression or amplification using FISH or BDISH. Okay, right. Now, I've just included this to show you how much of distance a specimen travels in the lab, okay? From the time it's received at reception to the time it's actually been processed, been put into formalin, it actually moves around the lab quite a lot. Now, this includes purely just the processing and then the immunohistochemical lab. And like I say that every step is important and needs to be quality controlled, it also is very important to note that mistakes can happen anywhere along these steps. So it's very important that we make sure the right patient's specimen gets to where it needs to go in terms of immunohistochemical analysis and assessment, okay? So we start from putting it in formalin. We obviously data entry, it grows depending if it's a mastectomy or if it's a core biopsy. Remember, we're putting it in 10% buffered formalin. It's put in a processor, there's embedding, obviously H&E staining. It goes out to the pathologist to go out for final sign-out. And then we obviously discuss this case in a combined group at the MDT that we have every Wednesday afternoon. Okay, so tumor size. So the accurate measurement of tumor is very important, and as the esteemed oncologist before me said, the CTS calculator takes a lot of these factors into their calculation. Tumor size, like you said, the grade, the age of the patient, and lymph node status. It's the strongest predictor of distant metastasis, disease-free, and survival outcome. And tumor sizes less than 1% have very little recurrence rate compared to those that are bigger. And it also correlates to the number of auxiliary nodes that are involved. Accurate identification of tumor boundary is also a prerequisite for valid assessment of resection margins. And we all know how important resection margins are. Francois is very particular about making sure that the margins are adequate. He's also asked us now to include the size of the tumor or DCIS that's involving a particular margin, because he's obviously told us about a few studies where the recurrence rate is actually higher if you have a more than, is it 4 millimeter margin that's involved, and if it's less, then it's probably not, how can we say, feasible to go back to remove more tissue. So this is where it's important that we give tumors their subtypes, and this is where morphology matters, because certain tumors obviously have prognostic value, and some of them are obviously worse performers when it comes to treatment outcomes. Obviously, in the first group, you want to have tubular, the mucinous type. There's a ductal type. Lobulars often have good outcomes. And then as you get further down into the grades that become higher, then you get the medullary-like types or apocrine types, which actually respond quite poorly to certain treatments. In our report, we also include the tumor grade, and the tumor grade is the modified Nottingham grading scale, and we use tumor differentiation, we use mitotic activity, and we use pleomorphism to get a score. The score is between 3 and 9. Obviously, higher scores would be put in the grade 3, while the lower scores would be put into grade 1 and 2. I'm not going to spend too long on this because I'm sure everybody's familiar with this when they encounter it. I'm just briefly going over it. So like I said, grade 1, 2, and 3 predicts outcome. It is recommended that grading is not restricted only to the invasive carcinoma of a special type, but you look at it in all the types of carcinomas. Auxiliary node status, it's the strongest predictor of disease-free survival, overall survival, and there's a direct relationship between the number of nodes involved and the risk of distant metastasis. And now we also know that it is important that if there's a clinical suspicion of micrometastasis or infiltrating tumor cells, it is prudent to actually do an immunohistochemical stain to highlight it. Even if you feel as though it is not enough to count count as a micromet, meaning it's close to 0.2 millimeters. It's important to give a count of the actual cells. Okay, and then this is just to highlight for you that on the node sections that we do, sometimes even at frozen section, Francois has a very good rate of lymph node sampling. He sends it to us. We put it under the microscope. Under frozen section process, and then we can often be able to detect micromets, or if we're not, we'll defer it to permanent sections and run immunohistochemical stains on it. And that is an epithelial marker, staining with brown, that highlights the invasive tumor cells that may not always be apparent on frozen sections. So it can be kind of critical in a sentinel node frozen section scenario, if you are uncertain, to be able to tell your surgeon, you know what, I'm a little bit concerned that there might be some abnormal cells here, but I think I'd like to defer it. And I think that it's fair that your surgeon gives you the benefit of the doubt for that as well. Lymphovascular invasion, it's an adverse feature, providing independent prognostic investigations. And it's very important that sometimes you need to highlight these vessels to actually identify the tumor emboli. And what we do is that this is quite obvious. Obviously, on the left-hand side, it's quite obvious to see that you've got tumor cells within a lymphovascular channel. But sometimes it's not that apparent, and you need to highlight it with a vascular marker and identify that it is in there. Margin status, very important. In our lab, we have multiple colors that we use to identify, to mark our margins. Francois' team's very good. They are always putting in sutures and telling us how to orientate the breast, which is extremely important, because if there is a margin involved, obviously he would need to know, the oncologist would need to know, and especially if it is a high-grade tumor, to be able to direct therapy in that area, or maybe even go back, okay? So so Francois orientates it quite well. Our registrars are taught how to orientate the breast when we get long sutures, short sutures, and so on. It is also important to note that we need to see if there's an axillary tail or not. If it's not been indicated or it's not been found, they are told to actually contact the clinician and make sure. Did they do an axillary clearance or not? If not, why not? Is it coming in a separate specimen? Because those are all important information that needs to be imparted to both surgeon and oncologist. Right, so we try and gross it as thoroughly as possible. And it's important that we put representative blocks of tumor into the cassettes so that we can assess the tumor in its totality. We also need to know if there is DCIS that is involving other quadrants of the breast. We are quite lucky or fortunate in the fact that the mammogram's already on the system and reported on by the time we actually get the breast samples. So if there is a history of neoadjuvant therapy and the registrar is not able to find the tumor, it is very, very helpful to go back to the mammogram, identify which quadrant the tumor was in, and then look for the tumor bed, because we have to identify tumor bed to make sure that there was actually a response to neoadjuvant therapy. So the mammogram actually helps us quite a lot, especially if we're not able to x-ray the breast, because that's also what we can do. We can set it off for x-ray. But it's probably easier and more resourceful to look at the mammogram and work out what's the area you should concentrate on sampling. I always also tell the registrars, the thing is that if you're taking more than 30 blocks on a breast cancer mastectomy case and you still can't find tumor, you need to really double check on the mammogram, was it a T2, was it a T4? If it's a huge lesion, you're not finding it, then there's something wrong with your sampling technique. Because in terms of costing, if you are taking 30 blocks plus, it becomes very expensive, and it also is unnecessary because you're actually not identifying what the response was to the tumor. Okay, now here it comes the important part about the margin status. Here you can see the black ink actually bordering where there's a focus of DCIS and invasive tumor. And that is important because we need to impart this to the surgeon. If it's just DCIS at that margin, you give it a Van Nuys score. And if it is obviously invasive tumor, you need to identify the size and the extent of the invasive tumor. Right, so now we're coming down to tumor response, and then, like I said, we use many different classification systems. One of them is obviously the Miller-Payne. It's graded from 1 to 5, 1 being obviously no response, 2 is less than 30%, 3 is 30 to 90, 4 is more than 90, and 5 is complete response. Okay, and that's helpful information to the treating oncologist. Okay, now I know that it's probably been ad infinitum that we know that ER-positive tumors do better than our triple negatives or our HER2 enriched, especially in state, because we are still fighting that battle of getting Herceptin onto our treatment list, which I think is criminal that we still haven't been able to get it in the Western Cape for our public patients. Okay, so we all know that you can get luminal A, luminal B, HER2 new enriched, and basal-like. Interestingly enough, our cohort of patients of the triple negative group are young. Obviously, they're young, black, and HIV positive, with often low CD4 counts. And I think this is a very interesting dynamic that we're finding in the state. And often these patients present with very advanced disease, and it's quite sad because they're in their reproductive years, they often have very young children. We've often diagnosed some patients while they were pregnant or breastfeeding, and then it would be ideal if we could offer them something more than just basic therapy for their high-grade tumors. And I know Louis did a talk on triple negative cancers recently. So we use surrogate markers, immunohistochemical surrogate markers, okay? That's ER, PR, HER2 new, Ki67. Our costing for those 4 tests, immunohistochemical 4, is around 600 times 4. So you're going to have a cost of about 2,400. If you're adding FISH to the diagnosis, it's usually about 3,200. So in total, to get an accurate diagnosis for a patient on the public side comes to around about 5,000 Rand, right? Now, if you take that and look at it in terms of, can we actually get sequencing? We've piloted, or we've tried to pilot, and I know Louis has also done a project on it, on STAT4, which is basically a molecular diagnosis. There has been a very high correlation rate, but I think it still has to be adopted by the NHLS. Louis can tell us more about that, but we are very excited if this is something that we can offer the patients. Okay, so when it comes to how do we assess the ER status, PR status, well, we look at proportion and intensity, and we call this the all-red score, and we give it an intensity out of 3, so 3 being a strong diffuse staining, and a proportion score out of 5, and then we get a total score out of 8, and obviously these scores are put down into the report. We also do scoring for HER2 new, 0, 1, 2, or 3, which is overexpressed, and then we also give a sorry, let me just move along. And then we also give a Ki67 score. So this is just briefly about HER2 new family receptors, and this is how we look for the staining pattern. This is HER2 new overexpression, and obviously that's a 3+. It's very important to understand that the correct fixation or the incorrect fixation of your specimen can actually adversely affect your HER2 new expression. So there have been a lot of research work done. There was a recent article published where they did a trial of putting specimens in 10% buffered formalin, unbuffered formalin, and 20% buffered formalin, and they found that there was actually incorrect HER2 new scores that were given that adversely affects patients' outcomes and treatment options. So it's very important that us in the lab also make sure that we have got the correct setup for accurate HER2/neu determination. So what do we do if a clinician requests, or the breast team requests us to do a HER2/neu investigation? Well, what we need to find out is obviously, is there truly HER2/neu amplification? And these are often on our HER2/2+ cases, which is equivocal. Now, this could be immunohistochemical assessment, this could be subjective pathological assessment, but it is very frequently that we will send it off for HER2/neu testing, and then we will get a diagnosis of whether it's amplified or not. We have also started adopting B-Dish onto our system, and we're very excited about being able to offer that to patients. So this is just a quick run through of the algorithm about HER2/neu testing. I'm not going to speak too much about that, but I just wanted to show you the pretty picture that you see there, where you see amplified HER2/neu gene signals, and the B-Dish, which is below that, and this is where you look for the amplification of your HER2/neu, and you look for it for an increase in the color of the probes. It's a bit technical, but I just wanted to just highlight for you that there are obviously other ancillary tests that can be used to determine HER2/neu amplification. Some very nice pictures there as well. Oh, right. And then the Ki-67. So why do you do it? Well, it's very important to find luminal A, luminal B, and it also is terms of grading for a tumor. It's not standardized. So what we've done now is that we've piloted AI technology in the lab to do an automated count of, or give us an automated count of Ki-67, because we've noticed that we have very high keys in our cohort. I'm not certain if that is a reflection of the aggressiveness of our tumors in our setting versus that we are maybe just, it's sort of like we're not really going to the hot spots and counting it. Remember, we have 3 or 4 pathologists that will be looking at the Ki-67s, and each one of them would have a different, objective count of a hotspot. So we are piloting this AI in our lab, and we are hoping to be able to put it on our, run it, put our specimens through the Ki-67 algorithm and be able to give very objective scores for Ki-67. So we're hoping that's going to come out in the end of this year. And then obviously special types of breast carcinomas. When we're looking for basal type of carcinoma, then we obviously do additional markers. It's not routinely done, but this is also based on the discretion of the assessing pathologist to see if they want to assess for, if there's other further profiles in the absence of molecular signatures. Can we actually use surrogates in terms of immunohistochemical analysis to be able to give more information to the clinicians? And there's obviously a lot of integration when it comes to the information gleaned from both the pathology report, sequencing if it's possible, and then treatment outcomes are affected by this. And I think that's my last slide. Here we go. Yes. Oh, yes, sorry. The take-home messages. So as the treating clinician, when you're reading a path report, when do you question it? Okay, so it's when your PR is positive, but your ER is negative. So then maybe just ask the pathologist, do you think the control worked? Okay, you don't have to ask that, but you could just say, do you think we should repeat the ER? If there is a tubular or lobular, which are often grade 1 carcinomas, and they're expressing HER2/neu or overexpressing HER2/neu. If you've got a grade 1, ER positive, PR positive, HER2 positive carcinoma, also just to double check that, when it means that HER2/neu is overexpressed in your grade 1s, and you need to in conjunction with your ER positivity, you need to question that as well. If you've got a grade 3 carcinoma, your ER is negative and you've got a key of less than 5%. Then there is something wrong, obviously, with the analysis of that tumor. Grade 3 carcinomas that technically should be triple negative but are expressing ER positivity like an 8 and a PR positivity of 8 as well. Medullary carcinomas are very rare. They have very specific morphological traits that accompany it, so you must also just ask for a second opinion. This is for the pathologist. And you can redo HER2/neu on the actual mastectomy. If you've got a grade 3 ER negative or ER positive, it is possible to ask for a HER2/neu repeat. And if you've got negativity of ER and PR positive, of negativity on the biopsy, then you can also redo it on the surgical specimen. And just to highlight the importance of multidisciplinary meetings, I think that all of us can safely agree that it is a combined effort. It's invaluable information that is imparted in these meetings. And I think it's a very important tool that we have on the public sector that can enable cohesive treatment of patients. And I think a lot of people, or a lot of groups are surprised, especially when our oncologists visit Harvard and the big breast cancer centers when they're going across for fellowship. When they say, but this is something you really need to adopt in South Africa. And then they say, no, we've been doing it. And so they're quite surprised that we actually have MDTs on the public sector side in South Africa. So I'm very happy for that. And I'd like to thank Francois for his excellent work in the meetings. I just wanted to also say we have 2 big clinics weekly, on average 30 to 40 patients. I'm happy to say that our immunohistochemical results, we have it on a Wednesday and a Friday. And I'm happy to say for the public sector side is that these reports go out within 2 days or 3 days after receiving a specimen, because we dedicate machines, the automated machines specifically to the breast clinic. I've convinced them to do that because Francois is so nice. So I just want to thank all the teams involved. And
thank you, Dharshnee. Any questions? Yeah, some questions.
Thank you for the excellent talk. You know, when you talk about pathology, it's coming very near to genetics. So I absolutely agree that the genetics, the molecular cannot stand alone. It must always be supported by the pathology, and in a way, vice versa. I've learned from the best, you know, Rika and Etienne and Justice and all these people, that genetics cannot override the knowledge that's there. So I just want to ask, this Ki67 being used to say a tumor is luminal A or B, it come up a lot in articles. You know, when I review papers, I see the people write, they use the tumor pathology and then talk about luminal A and B. So my advice is always that without the microarrays that was initially used to discover it, and the pathology is then used to approximate it as basically as surrogates. Can we really talk about that? So just to maybe use the word approximate or surrogate, or is it correct to talk about the Ki67 to make it into luminal A and B?
Just close to your mouth.
Ki67s can range quite dramatically from one pathologist's assessment to another. It can also range institutionally as well. So you would get pathologists at different institutions calling Ki67s differently based compared to another institution, right? So that is why I say that we need to have something that is validated, that is automated, that is objective, and that is accurate. Because luminal A and B becomes quite a challenge, you know? So in response to your question about whether we should say is approximately 15%, it's approximately 80% and so on. It is true that we should say that, but I think it's accepted that this is the best approximate of a biopsy. Now remember, a biopsy is a point in time of that tumor. And the tumor is heterogeneous, right? So you could have areas of hotspots, and you could have tumors that are there's clones that will be more aggressive than the other clones in different areas of that tumor specimen. So when you go for that biopsy, you are actually truly giving an approximate of what you are seeing on that biopsy specimen. It could very well be that when you get the mastectomy specimen, you find that that key is totally inaccurate. So you could have given it a key of less than 15 or 14%, which the St. Gallen criteria says, puts it in A or B, luminal category. But then when you get the mastectomy, and remember the clinicians treat now based on that, then when you get the mastectomy specimen, you find that this key in the hotspots is sitting at 60 to 70%. Now, were you wrong based on the biopsy? So it becomes a bit of a challenging matter. So key 67s, as important as it is, it's not truly, in my opinion, it's not truly representative of the tumor. It's the best version of what you could do at the time when you're seeing the biopsy.
Yeah, I think, I've been to a couple of units in the UK, and some of them don't even use keys. They don't do it. They say, no, it doesn't add much or whatever. But I think if a key is very low, if your key is less than 10%, then it probably is low. And if it's quite high, then it probably is high. But it's this sort of in-between group that makes it difficult. Yeah. No, it is a surrogate. It's not true genetics, microarray answer. It's not a blueprint. It's a surrogate. And a lot of articles use that as a surrogate. Maybe they should just state it. Yeah. Mm. Yeah. Well, they should know that. Okay. Any other questions? There's one there.
Thank you for that excellent presentation. I wanted to know, as a pathologist, what do you consider to be pathological complete response on a specimen?
What would you consider?
Yeah.
All right. So
And also, what is negative margins for you?
Oh, okay. Well, right. So, answer your first question. We would adopt one of the scales would be Miller-Payne. I explained that to you. It goes from 0 to 5. 0 meaning no response, 5 being complete response, and then in between, it's based between less than 30%, 30 to 90, or more than 90% response. And then you'll give it the appropriate number based on that. So we've encouraged the registrars now to include that in their report and so when there is new adjuvant treatment, if they are unable to find the tumor, we want them to find the tumor bed. If they are unable to find the tumor bed just purely on morphology, we insist that they run immunohistochemical markers like a CD68, which is basically just to highlight your hemosiderin-laden macrophages in area of the tumor bed to identify that that's where it was. So, and to run an immunohistochemical stain that is an epithelial marker to make sure that you don't have isolated residual cells. If we see nothing in terms of the epithelial marker staining completely negative in that tumor bed, we'll give it a complete pathological response. But what we will do, obviously, is that we will quantify the amount of residual tumor that is there in a treated breast, and then obviously give it accordingly. Like, is it less than 50%, more than 50, more than 90, and so on and so forth. As far as I know, if there is DCIS and no invasive tumor, it's considered complete. Okay? Which I think a lot of registrars struggle with, but surely there's still some sort of neoplastic process going on here. But we would consider that complete response as well. And when it comes to a margin, and then also what we do is that we look for treatment effect in the lymph nodes. Okay? So what happens is that When we get the lymph nodes in the axillary node dissection, we will sample it. If we see tumor in the nodes, obviously we'll count that as either macromets, micromets, or infiltrating tumor cells, diagnosed either by immunohistochemistry or by morphology, and we'll specify. And if we see treatment response in the nodes, we will also mention that into the report as well. When it comes to margin status, well, if it's a microdiscectomy, for instance, for DCIS, then obviously we go by certain margins based on the Fanai score, and then we will quantify the margin status based on that. So is it more than 2 millimeters, more than 1 millimeter, less than 1 millimeter, is it at the margin, and so on and so forth, and then we'll have to indicate that in the report. Remember, the Fanai score takes margin status into account when it's giving a score. And based on the score that you get, then the responding clinicians, the clinician will either decide to leave it alone, mastectomy, or just give treatment to that area. And when it comes to invasive tumor margins on the mastectomy, ideally we look for margins more than 20 millimeters. I don't know if that is, for us, that's a good clearance.
Yeah, that doesn't really make a difference. So you need to be clear of ink. That's positive or negative. For invasive cancer and for DCIS, we consider 2 millimeters. The problem is if you've got invasive cancer and DCIS, I mean, what I do is I look at the major component. So if it's major component of the tumor is invasive, then we'll use tumor on ink. Yeah. And if it's more DCIS, then you want to actually have wider margins. You're more aggressive in treating DCIS, getting wider margins, because you really just don't want to come back again.
And the wide local excisions that Francois sends, he's quite thorough because he often sends shade margins as well. So if he's not convinced that in theatre he's got everything, he'll often send shade margins just lateral to the closest point that he thinks tumor is going to be involved in. So that actually helps quite a lot. So we put that into the report. So what will happen is in a wide local excision, if you have tumor at that cautery margin, the medial margin, the medial shave is actually taken as the true margin. So then we must include on that medial margin. And then he puts a suture at the medial aspect of that margin or the lateral aspect, so we know which is the closest point touching that involved margin on the wide local excision. So that's also very helpful, especially on the wide locals.
Yeah.